Our next presenter is Jeff Holt. Jeff has over 16 years of operational, strategic, and fiscal experience as a progressive executive leader in healthcare. He went to the University of New York at Geneseo with a BS in biology, and then has earned a master's in public administration from NYU. And then he spent a large portion of his career at NYU in cardiology. He oversaw high-level strategic planning and operations for clinical, educational, and research programs that included oversight of 172 cardiologists, 120 staff members, and responsibility of over $54 million of operating budget. In 2013, Jeff was recruited back to Buffalo, New York, to his hometown, where he was Vice President of Advanced Orthopedic and Spine Center at Buffalo General Medical Center. And then quickly, that role expanded to include oversight of multiple clinical programs, service lines, and the role of System Vice President of Clinical and Surgical Services. Jeff currently works as an executive consultant and recently relocated to New Jersey to establish a life with his daughter in the greater tri-state area. So everybody, please welcome Jeff Holt.
Thank you. That's a flattering introduction. I'm not sure that I can uphold all of those qualities and characteristics, but thank you for having me today. So when Neuro invited me to speak on the topic of the benefits of hospital employment, it got me to thinking, am I an endorser, an inside person that's trying to sway you to either consider moving in that direction, whether established in your career or new right out of your training? That's not the case necessarily. So today I'll focus on offering you perspective as to what employment may look like if in fact you choose to align, affiliate, or directly employ with an acute care facility or other type of hospital. So some qualifiers. After I put this slide together, I thought to myself, yikes, I didn't want to come across as trying to validate who I am, but I wanted to give you a little bit of background as to my experience in both strategic planning, physician alignment, recruitment, population health, in tandem with really taking ground zero organizations and turning them around with a focus on a strong value proposition to the community, most notably lowering costs and improving quality. So your professional journey, some of you in the room are physicians, or you've taken care of patients in the past. I mean, really, my hat as a layperson administrator once a BS in bio that aspired to be in medicine in some capacity. My hat off to all of you who partake in patient care. But I won't run through the bullets here, but simply I think that you've pursued compassionate care to prevent, maintain, improve, restore, heal, resuscitate, support. You've had a rigorous and intense road, and what happens next, right? I mean, where do you go, and what's the best fit environment for you? And then obviously at the bottom, a little talk about patient and family-centered care. In tandem with your goals, how do we focus on evolving a model in healthcare that's both viable and sustainable? So my little Peanut, my daughter, 3.5 years old, Natalia, is outside hanging out. And I thought of her when I was putting together this presentation. And it says here, a book that I read to her, it said, "You're here for a reason." And while this seems rather parochial for a presentation like this, I started thinking to myself, if we didn't just keep this level of simplicity in kind of addressing each of the decision points in our life, would we have a clearer elucidation as to where we were progressing? So what I really took from this book was, purpose-driven, embracing the unknown, dealing with ambiguity, but relying on the power for you to make your own decisions. Yet, ironically enough, some people don't even explore what their environment will look like. So they become tunnel visioned and say, I'm really driven to achieve X, and these are my personal goals, and these are my global overarching goals for my entire career journey, but what's that best fit model? So some things to consider, obviously, and please take this as no insult, some of you, whether established or not in your own career. When I thought about the benefits of hospital employment, I started thinking, what would individuals' quality of life look like with a balance to the acute setting or the subacute setting or a specialized hospital or a skilled nursing facility, anywhere throughout the continuum in a more formal employment setting with an institution or an organization versus a private practice. Work-life balance, lifestyle, degrees of autonomy. So I tried to arrange this, although I'm not sure I did a good job, from the highest level of autonomy at the top bullet down to what I believe to be, in my own perspective, the lowest level of autonomy. What I see here is that, in private practice, sometimes you have a startup opportunity. Oftentimes you're inheriting a practice, you're in the middle of a transition of practice. There's a physician or a group of physicians whom are retiring or transitioning out of their practice. So that's probably the highest level of autonomy, decision-making, driving your own strategy. And then kind of layering down, going into an established community practice, whether that's single specialty versus multi-specialty practice, the degrees of coverage in that, and having the ability of people to collaborate with and to lean on during critical and difficult clinical decisions. And then next, faculty practice. So within the School of Medicine academic setting, you'll find a lot of faculty group practices, faculty practice models, whereby it's a captive PC model typically. The hospital owns those practices, but there's some level of independence still. And then partial hospital or group practice employment. So this is an interesting one. There's something called a reverse lease model. That's at least my terminology for it. So you can be in private practice, but the captive PC or the hospital itself actually leases percentage of your effort. So when I was back in the day, when I was starting at NYU Langone as the administrator of cardiology, I would carve out each half day. I don't think this was necessarily novel or innovative, so don't write this down. But each half day is 10%, and you have a total of 100% for the week. So then you start allocating effort like that, and you sit with physicians in the community and say, we're willing to lease some of your effort for nuclear reads or for interventional cardiology, electrophysiology. And then lastly, pure hospital employment. And we'll delve into that a little bit further in the presentation. That can be a direct model in an inpatient unit. It can be over clinical programs and service lines in tandem with some outpatient practice setting and or clinic setting model. So identifying the right fit. This is all I could come up with, but I'm sure there's far more throughout the continuum in the hospital, if you will, model. So there's pure bona fide academic schools of medicine, medical centers, like I'll keep leaning on my previous experience at NYU Langone, where you're either employed directly by the school or you're employed by the hospital. Now, whether the majority of people in here may say, yeah, I get it, but sometimes people don't know who they're employed by, or they have a split employment model where their lines are coming from the source of the hospital and the source of the school, but they don't know whom their ultimate employer is because it's kind of bifurcated in terms of who gets employed by whom. The community hospital system with a School of Medicine affiliation, that's happening rapidly now throughout the region. I think as many community hospital systems realize that bigger is not necessarily better, but their alignment with the right party will only assist them in differentiating and creating a stronger brand for the community. There are community hospital systems, as you know. There are standalone community hospitals, although these are coming far and few between. I believe in the current state that I reside in New Jersey, there may be a handful left. I've kind of kept my finger on the pulse as to what those look like, but I think they'll soon be integrated into some system or have some loose affiliation agreement. Government hospitals, state VA, even community-based hospitals with subsidies directly from the government, military hospitals, specialty hospitals. So the point of this slide was that I'm really running through all different types of hospitals where you can be employed at. But they're definitely different, not only in composition, complexion, but flow, clinical paradigms, culture, and leadership structure. Metric-based performance. I got a little snarky with this one because I thought to myself, I once considered myself a very primitive scientist when I was pipetting HTBL and other cancer cells within a research lab and trying to impress others, but I don't even think I kept those cells alive for more than a couple of months. So, but in the hospital environment, yes, your world would be as scientific as you kind of wished it to be as scientists. We live in such a data-driven and metric-driven world now that gone is the day of subjective decision-making based on whimsy and or one's intuition. People are always looking for empirical data to support and back up their decision making. So I started out with the buzzword of, I don't even know if it's of the decade, of the century, work RVUs, work relative value units. You'll find that those are some of the most common mechanisms or use of developing compensation for physicians and other allied professionals. Within the environment, you're going to see so many metrics around throughput, from admissions to discharges to observation, ED cases, diagnostic, ancillary testing, procedural and surgical volume, both in and outpatient, and each of them weighted and viewed differently, right? So, I won't say a dollar's not a dollar here, but they're not viewed the same by hospital leadership. I had to be delicate about that one. So, making the right decisions versus, figuring out how to diversify your portfolio is ever so important into creating a sustainable and viable model in the acute setting. So when we look at all of those metrics, we start designing strategy and making decisions around, what it would look like to create a broader scope of services and programs that will allow for a lower length of stay and improved quality outcomes. Physician engagement, that'll be key. We'll chat a little bit about that in a while. Employee engagement, it's really becoming a top 3 priority, those two together. And then value-based reimbursements. I'm sure you know that many reimbursements for both government, Medicare, Medicaid, and commercial insurances are getting pinned right now around quality and outcomes. So gone is the day where a fee-for-service environment exists and you can have, not to say that this happened, but you could have futile testing and or unmanaged or monitored testing without any type of quality tracking related to that reimbursement. And then bundled payment care improvement initiatives. Those are huge now too, Medicare driven around different DRG and disease states. And literally the metrics are vast. I mean, you can imagine that amidst all this, and I won't bore you too much with this slide, I was a little off topic here, but I want to give you a nice glimpse as to what the hospital environment looks like, because these are words and concepts that you'll be dealing with, intimately involved with managing, troubleshooting, working through these challenges and obstacles hand in hand with your physician peers and other administrators. Utilization Management. So think comparative analysis to like patients for the same DRG. And literally, when I tell you, there are shared physician savings programs where physician gets scorecards, and part of my role in my last organization was to sit down and say, hey, listen, you did X number of knee revisions, hip replacements, knee replacements, all at the severity of illness 1, 2, 3, 4. Here's how you compare to your peers locally at like organizations, regionally, nationally. Here are the disparities and variance between your cost per case, your length of stay, your blood utilization. And there are data and analytics out there through Crimson and other modalities that are really drilling it down to physician performance on an individual level. And it's not punitive. It could be if you don't have the savvy and the ability to, I think, build rapport with those stakeholders. It's more so, how do we routinize and create consistent standardization around evidence-based medicine and standards of care? And is there a way to work with you on your preferences that may be able to lower that cost per case and decrease length of stay while upholding the integrity of the quality of services we provide? HCAPS, I think I spelled that right. Hospital Consumer Assessment of Health something physician services. No, it's healthcare providers and systems. So patient satisfaction, that's huge. Again, reimbursements through Medicare and Medicaid are being tied to that metric. People are getting fired, I hate to say that, but it's true, over that metric, because when you look at an HCAP survey, it's everything from, would you rate this hospital excellent, and is the hospital clean? Was the communication with your physicians clear? Was your unit quiet? And it's an all or nothing philosophy. So the selections that a patient has are never, sometimes, maybe, or always, and the hospital only gets credit for always. Now, the hospital and the leaders and the anyone in the care team cannot coach and or bait patients and say you may receive a survey. You can't even provide some type of standardized scripting around that. So you imagine how difficult that is to achieve those results, and this will be your environment if you so choose the acute setting. I mean, it's going to be an environment anyways if you practice care within the hospital. So how will you pay me, and what are your expectations, right? I think many people that come out of residency and fellowship, the models where you have an income guarantee, the top line, are few and far between nowadays. However, I think you see it happening where someone has a 1 week on, 1 week off, 2 week on, 2 week off, and they're hospitalists or they're neurointensivists, or they have a standardized role exclusively in the inpatient setting with no outpatient type care necessarily sprinkled in. But some of the other buzzwords you'll hear as you negotiate your compensation, or what compensation may look like, are the use of standardized reporting and benchmarking for the blended average fair market value compensation by specialty. So when an organization says our willingness to pay is based on national standards, that's what they mean. They're turning to the Sullivan-Cotters, the MGMA standards, and they're looking at percentiles of compensation based on tiers of productivity. So, typically you don't see people or organizations go below the 50th percentile, but unless someone has a proven track record of productivity and already is established, they may not go much higher than 55 or 60 either. Something to consider in evaluating your compensation in the employment setting, in the hospital setting rather, is that the word total compensation, you really want to get clarity around that, because there are a lot of components of compensation. So people use the word like, what's my salary, or what's my annual compensation. You really don't understand what the total compensation is, and how I've parsed it out here is you have a fixed base, and that base is typically fringe, so that means your benefits are going to be on that base itself. And then, this is a cute way of doing it, but how organizations do not have to pay your fringe benefits on additional compensation is they actually parse that out or carve it out into a different line called the supplemental pay, whether variable, supplemental, or fixed. It may be a standing dollar amount above the cap or the threshold by which that organization is willing to provide you fringe benefits. Your clinical productivity incentives, so if you achieve a work RVU productivity target, are you compensated after that threshold, a certain dollar per RVU? Are there dollar amounts around collective? I put collective bonus allocation, so being very careful around the concept of Stark, but when in a fully employed model, if you achieve both quality, I won't say volume, and other targets for a unit and entity, and then electrophysiology, I'll keep going back to cardiology or other specialties, does that unit get a dollar amount into that division, department, cost center, or is it allocated to all of the key physician stakeholders? Quality-based incentives, that's huge. A lot of hospitals and hospital systems are providing quality-based incentives, tying them into government programs and using them as a dashboard. And then I had mentioned earlier the shared savings program, which synonymously we've heard of a gain sharing program. That's not illegal to call it that, but that's just another word that one uses, is that, again, strict, rigid data production and adherence to quality outcomes and utilization targets with transparency around physician productivity and results can yield actual savings and checks directly to physicians for their performance. So some hospitals do it well. Within their employment agreements to new physicians and standing physicians, they provide a detailed effort and compensation grid. When I say detailed, I mean like, you're going to spend 1/2 day a week in this clinic. You're going to spend approximately, but not limited to, X number of half days in X, Y, and Z. So I think that's good. The more explicit it is, the less ambiguity you have to carry with you as to how you may be deployed, used, and or shared sometimes within the hospital setting. So I think you should demand that without sounding too forceful. And then once you get into a hospital setting, you typically have physician time studies, where every quarter or semi-annually, someone's going to come to you and say like, hey, how are you spending your time? And then they'll want to compare that to what are you actually doing based on your employment agreement and based on the needs of that division, unit, or overarching program or service line. So one FTE, full-time equivalent, and time spent, can be drilled down into several different buckets: your clinical time, administrative time, leadership time, research time, education. And then really the question is, where are the sources of funding for each of those buckets coming from? The clinical part makes sense. The administrative piece, typically that's a subsidy, right? Whether it's the hospital proper, or there are grants for this, or there are other components of revenue streams that may be able to cross-cover loss leading or non-revenue generating components of one's effort. And you won't see that within an employment agreement. No one's going to tell you what the source is. They're not going to say, okay, this is coming from a quasi-endowment over in our School of Medicine. But it's good to know whether or not there's security around the funding for each of your endeavors. Clinical effort distribution. So I thought it was important to kind of look at just this one bucket and kind of go a little further into it. So testing, supervision, and performance, procedures, surgeries, inpatient consultation, outpatient consultation, and telemedicine are just a few of the clinical distributions of effort that may occur, and I'm sure I'm missing some there too. So back to the fair market value compensation. You may get a first-year guarantee. Some people out of residency and fellowship are still getting first-year guarantees. If I were the administrator behind the agreement, I'd be weary to do so, but I think you can bridge someone for a ramp-up period of time if you're expecting them to establish either a practice in a captive model and or become busy in the inpatient setting in tandem with establishing a practice or running a program or driving growth within some type of service line. So that first year makes sense for someone new. And then in subsequent years and future years, you would pay, the compensation would be structured as a payoff of a draw. Now, you can pay off of a draw based on the historical first year's productivity or based on the original compensation within the first year agreement. I think it's not so nice to look at the first year's productivity and scale someone's salary there, but say, like, listen, we gave you that year. We're going to hold the compensation where it was originally, but here are the work relative value unit target in terms of your productivity that you'd be striving for, and then we're going to reconcile quarterly, semi-annually. So if you're less productive, unfortunately, we would then start altering your salary incrementally along the way. If you're more productive, we'll increase your salary along the way. So this is a pretty standard practice. Again, work RVU driven, dollar per RVU, and I think I've gone over all that piece. But you can definitely ask for a pro forma or a business plan around you as an individual, because all hospitals will have it. There's a projection that they'll use for 1 to 3 years that'll show your projected revenues in year one, your projected productivity, how they're going to support you. I think as a part of your negotiation for employment within a hospital setting, you should really explore whether or not there's a demand for your specialty or a niche. And what I mean by that is, are the physicians in the community or the other employed physicians, are they going to support you? Do they have new business development and networking teams that are going to corral market share and drive it your way, or is it your own responsibility? And believe it or not, sometimes you won't have those resources, and it will be your own responsibility, and that'll make things even more difficult in the competitive market. And that comes back to, how are you, as an individual provider, going to differentiate your services and build rapport with both your patients and referring physicians. The benefits of hospital employment, and I think I have one slide on this. Larger acute hospitals and hospital systems may have some more comprehensive benefits, right? You got better medical plans, typically dental, optical, and the like, 403B plans. They have other support departments that smaller institutions, or as my peer will speak about, I think, next, in the outpatient setting, you may not have all of these corporate overhead resources, if you will, that you can actually use to your advantage as a physician or a caretaker, a provider. And possibly more cash on hand. If it's a well-run hospital or hospital system, those margins, though only 3 to 5.5%, should be of a massive dollar amount. And with that, there should be some fiscal stability. Although, as we know, the majority of these hospitals are continuing to acquire, develop, grow, reinvest in their capital plan. So it's not that there's money just hanging out there. And then the prestige and the reputation. We'd actually have employment, not even employment models, we'd have affiliation models where when you're affiliated with an academic school of medicine, you can get a part-time faculty title, as many of you probably have or may pursue. And with that comes the prestige of that affiliation and that brand name to your business card, right? I'm a clinical assistant professor or at New York Presbyterian Columbia, and I'm not. But if that was on your card, that may help you, sell your services and enhance your reputation based on their incredible U.S. News and World Report rankings and in many of their fields. And then another benefit of being in the hospital setting, there's various opportunities, right? So you're talking about juggernauts here. With when we say 5% margin, you could have on a $2 billion organization, you can have $100 million that is pure profit at the end of it, that you can determine how you're best going to allocate and move that back into the organization. And with that, there are a lot of unfunded mandates that private practice outpatient settings couldn't handle. So tackling population health more globally with comprehensive programs, access to new technology and innovative therapeutics, research, unfunded research. So if that's a passion of yours and you think about, should I be a private practitioner, or should I work in an outpatient setting, or should I work in the acute setting, this is a draw for many people, right? That there's, Mrs. Smith around the corner, whom has been a longstanding friend of Dr. Fisher. And Dr. Fisher, I went to dinner with her last night, and she donated $2 million for a brand new program in hyperlipidemia. And that's going to fund all of your research and the goals that you've had in tandem with your clinical milestones, personally and professionally. What are the sometimes not so attractive features of the hospital? I'm always delicate with this one too. This is being recorded, and hopefully it's not on like Channel 2 tonight or something. But there's bureaucracy, as there is anywhere, and sometimes that's difficult to navigate, especially for strong personalities and those who have an opinion, and additionally for those who are willing to challenge the status quo to do the right thing on behalf of the whole. Time to execute is often lengthy, and it's delayed, right? There's committee upon committee sometimes, and depending on the workflow and the process behind it, there are intentional stops and holds. So sometimes you can't get to that finish line and where you want it to go, or at the pace that you want it to go. And let's just be honest, and this can happen in the private practice setting too, in a multi-specialty practice. There are often unilateral decisions. At organizations where, despite the feedback from many stakeholders or a good synergy and dynamic between physicians, physician leaders, and administrators, that someone does have the authority in this hierarchical structure to make a decision and say, this is the way it's going to be. And then the exciting fourth bullet that I stutter on is politics. I mean, it's these hospitals, whether community-based or academic-based, and there's tons of politics. So you'll run into that anywhere, right, in any industry. So it's really not, I don't want to harp on that or make it a big deal, but these are some of the unattractive pieces. The volatile union environments, had to be careful there, but I was up in my hometown of Buffalo for 5 years, and yeah, it's interesting, eye-opening, a learning experience, and you have to figure out a savvy way to navigate and best leverage the best interests of your patients and their families against rules and regulations that may not sometimes be conducive to immediate action the way you'd like it to be. And matrix leadership. I thought about this for a second, and I was like, I don't even know if I could read that line appropriately, but your boss's 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 boss may actually be your boss and all others in between. And that's a matrix organization, right? It's like, who do you report to? People used to ask me that at NYU, and I was like, the vice dean of the medical center, the chief of cardiology, the chair of the Department of Medicine, and like 3 or 4 other people. And they're like, no, seriously, like, who do you report to directly? And I was like, maybe 2 of them, but the other ones indirectly, with just as much integration and kind of interaction, rather. That being said, that's not uncommon for physicians within an employed model within the hospital setting either. So my recommendations, I'm not sure how utterly valuable they are, but I'd really encourage you to explore, shadow, percept, like facilities and organizations, right? So if you're convinced that you would do well in a community hospital, standalone system, academic medical center, look at a variety of those, because you're going to see different features and components and characteristics in each of them, though a similar setting. And it'll be worth you taking a deeper look before you get caught up with how amazing their clinical programs are, or their brand reputation is, or their novel therapeutics and innovative technologies and things like that, right? Those differentiators are important, but go in there, get a feel of it, and really look at these things. This would be my pure advice. How do staff interact with physicians? That's important, right? We talked about physician engagement earlier on. That is a huge metric for us as hospital executives that we look at, is how engaged are physicians? Do they champion behind us? Do they feel that they have a voice? Are they a part of the leadership team driving the decisions for incremental growth and progress, while upholding high quality and low cost care and improving access? What is physician leadership like? Do they sit on committees? Are they active on committees? Are the committees like dilapidated and no one has any goals or milestones and people are just like, drinking coffee and falling asleep? I mean, those are some things you really want to take a look at, because what you want to see is that the physicians are front and center to the decision making, that they are the direct advisors to the layperson administrator like myself, because I couldn't imagine making unilateral decisions on what I thought was best based on my theoretical and actual learnings over the last 16 years without having a direct physician leader sitting right next to me, guiding on decisions that were obviously evidence-based and best practice driven. And then is there an us versus them or a synergy? So I think that's important, to look at the culture and the relationships within organizations that you may choose to be employed by, and determine, is this somewhere where I can see myself having a good quality of life at work?